where we were willing to be.
But then what's
Okay, we're going to get started now. We expect one more speaker to arrive momentarily. Don't want to hold up everything. We have a limited amount of time. I'm Paul Starr. I'm just here to introduce today's speakers. And we are fortunate today to have a very strong group to discuss the question of implementing healthcare reform. Are the states ready, willing, and able? We have a very strong representation from the New England and Mid-Atlantic states, but I'm sure the discussion will range far and wide. I'll begin with the speaker at the far end of the table, who is Richard Nathan, who comes back to Princeton, where he taught for many years in the Woodrow Wilson School. He left here for some mysterious reason to become director of the Rockefeller Institute at the State University of New York in Albany, where he was also distinguished professor of political science and public policy. Before Princeton, he had years of experience in Washington. He was I think he was the deputy director of the Office of Management and Budget, assistant director of the Office of Management and Budget. He was deputy undersecretary of what used to be called the Department of Health, Education, and Welfare. And he has worked for many years on questions related to the implementation of policy and on questions related to federalism, including those questions having to do with health policy and federalism. So very knowledgeable about the issues on the agenda today. The next speaker is coming again from the far end of the table is Don George, who comes to us this afternoon from Vermont. He joined Blue Cross Blue Shield of Vermont in 1993, and he's held various positions in that organization, most recently vice president of the company's managed healthcare systems division, and senior vice president and chief operating officer of the Vermont Health Plan. And as vice president of that plan's managed health services, health systems division, he led the development of quality programs, medical management programs that earned the plan recognition as one of the top 50 health plans by U.S. News and World Report. Not that U.S. News and World Report is the last word on any ranking, but but nonetheless, he also oversaw the performance improvement programs at the plan that were recognized by the Vermont Council for Quality with the Governor's Award for Performance Excellence. Next on the panel, coming to us today from Connecticut, is Kevin Lembo, who is the state controller of Connecticut. He was elected to that position in 2010 after decades of experience in government, finance, and healthcare. And most recently, he served 2 terms as Connecticut's first healthcare advocate, beginning in 2004. And as healthcare advocate, he helped thousands of Connecticut residents navigate the complexities of the healthcare system. He's been, for years, an advocate for patients and their families who've been denied coverage or treatment, and he's returned more than $25 million to consumers over the past 6 years. Finally, Heather Howard comes to us with both federal and state experience, and very likely, quite soon, local experience, trying out every level of government. She served as New Jersey's Commissioner of Health and Senior Services from 2008 to 2010, overseeing a cabinet-level agency with 1,750 employees and a budget of $3.6 billion. And at that agency, she was responsible for public health services, the regulation of healthcare institutions, hospital financing, senior services, and much else. Before that, she was Governor John Corzine's chief policy counsel. And before coming to work here in New Jersey, she served on the staff of the U.S. Senate for 5 years. She was associate director of the White House Domestic Policy Council and Senior Policy Advisor for First Lady Hillary Clinton, and much else. And I probably should not mention that she's now a candidate for the Borough Council here in Princeton. But since she's running unopposed, we can't even give equal time to an opponent. So with that, I will turn it over to Heather.
Cleared the field, clearly. Well, this is terrific. Thank you, Professor Starr. We've got, and I think we're waiting for Commissioner Considine from the Department of Banking and Insurance from New Jersey so that we can complete the Northeastern group that we've got here. We've got a wonderful panel, and I'm glad to see I've got a number of students from my class I'm teaching on health reform implementation, who I know are going to have terrific questions, right? So this is great. We want to kick it off. Dick, I think we talked about we were going to let you go first,
Okay.
and then we'll work our way down. Thank you.
Thank you, Heather. I can make a very short talk. Are the states ready and able? Are they ready? No. Are they able? Maybe. This is a chance for us to look at the Scott-Brown effect of national health policy. If it wasn't for Massachusetts and Scott-Brown, there wouldn't be as much going on in depth and much of it below the radar in every state about how to set up an exchange and what you're going to have to tackle and what the challenges are. My long-term interest when I taught here and since then, as Paul mentioned, is states and American federalism, and particularly implementation. So this is a feast time for my colleague Larry Brown from Columbia University and I, who are doing studies now in 8 states on implementation challenges of health reform, studies supported by, and we paid a visit to them today, the Robert Wood Johnson Foundation. I'm also a member, and I brought copies if anybody wants it, required reading now up there, another project, a very good project of the Johnson Foundation, an experts group who did what's called and have published a toolkit on setting up, designing a state health insurance exchange. There's an immense amount of activity and a cornucopia of information about what's going on in the states. You don't have to leave your keyboard. The Johnson Foundation is funding something called the Health Reforum, clever, right? The Reforum is in parentheses, and every state's documents that they can get their hands on are indexed in an elaborate, important system looking at all the different challenges for setting up an exchange. I'm anxious to listen to 2 of our speakers and maybe a third to hear about what's happening, because that's the most important part, what you can learn by going out in the country. And that's what Professor Brown and I have been doing. And what we've done, in short, in a capsule, is this is an initiative of the Johnson Foundation where the idea is to work within the belly of the beast, to find change agents inside a government, not necessarily the political people, but the top and savvy professional people who can work together with experts and each other. The most important learning has been federalism learning, where wonderful, smart people, you go out there and you meet these people, and Larry and I often come away thinking, they are so heroic. They work so hard. They care so much. And they're up against it now, and they're underappreciated, and they've got an awful lot of work to do. Now, I would like to say something positive, because this is a real downer period. The debate about national policy, domestic policy, and particularly focusing more and more on the costs and future of health programs and the health industry. And nobody knows it better than Paul, whose work has influenced and taught all of us. So I want to mention some specifics, the kind of things that may or may not be mentioned by our speakers that are a little bit upbeat. things that maybe will work for exchanges. There are already some states, Louisiana says, no, we're not going to do it. Let Kathleen do it. And the law says that there is a default position that the Secretary, HHS, can, and the law even says, select a nonprofit, or not necessarily has to do that, to run an exchange in the state. So that's going on. There's, at a high level, there's a lot of opposition to the whole idea of the law and fighting it in the courts by state attorneys general, but down in the bowels of government, there are people who are saying and thinking, we don't want the feds to do it. If this law does go into effect, if it's not declared unconstitutional or is shrunken by the Congress, we want to do it. We don't want the feds to do it. That's still, I think, widely felt. The people are working to get ready and hoping they don't have to do it in a lot of states. And there are various different organizations, particularly working with the states that have a high degree of skepticism. So let me just mention, and I brought some copies of this. If anybody's interested, you can read them. Three things quickly that might work. And I'm writing a paper now as part of this Johnson Foundation project as one of the people working on it, on auto-enrollment. Now here's something that really me go, you know, my eyes goes over. Auto-enrollment, why can that change the world? Well, it could if people come in and you have enough coverage of exchanges for Medicaid, which is mostly managed care, and secondly, and also for the subsidies, the advanced tax credit for people who are supported under the new Affordable Care Act. So what if the government system, enrollment system, worked so that you were automatically enrolled? The law says you have 30 days to change your enrollment, but they pick out something that looks like it would be right for you, and the law also says there are navigators who can help you decide to do something different or can guide and assist you. So there are things that could make the pools big enough. And maybe, like in California, where the law is very strong about active purchasing, influencing the market, getting more players in the market, and picking and choosing among affordable care projects, policies that you can use your advanced care subsidy to purchase. So the states are different. If there's any one thing you want to know about states, they're different. They're diverse. So it's very important that people here and people throughout the country are like Diogenes looking for a lantern to find where are there going to be things that are going to be sleeper or surprise developments that are going to make the exchanges and the state role a strong role, particularly for reform and cost control. Put it right there. Cost control is at the top of the list. And do they have an incentive to control costs? I'm not sure. Is it politically something that state governments like California says it wants to, that they're going to tackle, but they didn't really tackle it in the connector program in Massachusetts, which of course is the one exchange that exists. So there are provisions of the law to review rate changes by insurers, to enroll people in insurance, to try to get more competition to cause the different providers, insurers and providers to come up with strong programs. And the law says, the Affordable Care Act. And if anything's on the front burner, it's the affordability of health care. The president made a speech today. It's going to be with us as a central issue of American life, and states are in the picture in a big way. So I am looking forward to being educated by now you too, Tom.
And let me just say, I'm really pleased that we're joined by Commissioner Considine of the New Jersey Department of Banking and Insurance, and maybe we'll introduce you more fully when we get down to you, but sure. We've got the Northeast Coast now covered, but we'll start with Vermont, Don, if we can.
Well, thank you, Heather, for inviting me here to talk about this important topic and to share an evening with you on your beautiful campus. When I think about the state's readiness, willingness, and ability to implement reforms, I generally would put them into one of three different categories. The first being those states that remain philosophically opposed to much of what's included in the new federal law. I think that they are still debating the politics of reform that were part of the federal health care reform debate. And they may be working on an exchange, or they may be willing to let the federal government, assuming that they're not successful in legal challenges on the law, they may be willing to let the federal government set up their exchange for them. I think the second category probably is the majority of the states. There are those that are not still engaged in the political debate around federal reform, and that they are busying themselves today with implementing and developing an exchange for their state and in implementing the reforms that are included in the federal law. The third category, and I think it's probably the smaller category among the states, are those that are driving their own state reform agendas through the federal framework. They either have previously developed or they are rapidly developing their own state-based health policy reform agenda. And they are going to use the federal framework of exchanges and subsidies through which they're going to further a health policy agenda that they think will be to the betterment of their states. The state of Vermont, as many of you may be aware, is a state that most would put into that third category. So I think the fundamental question beyond implementation that we should ask ourselves is relative to willingness, ability, and readiness to implement reforms. Is your state driving reform forward? Is your state comprised of governments and healthcare stakeholders that are developing their own health reform policy and viewing themselves as advocates and passionate champions of reform? So why do I suggest that this is the important issue and the important consideration? Federal reform provides for a major expansion of Medicaid and private insurance coverage. And it does provide some funding in the form of subsidies for individuals who are within a certain percentage of the federal definition of poverty. But the role of controlling healthcare costs in order to sustain that broad increase in coverage in both Medicaid and private insurance coverage will ultimately fall to the states. It will ultimately fall to the states to fund and sustain the broadest expansion in healthcare coverage that our nation has ever seen in the time that we have had private health insurance coverage and government health insurance coverage in the country. The reason for this is that the simple truth of federal healthcare reform and of healthcare delivery is that, well, healthcare may be a compelling national issue. Healthcare is delivered locally. And healthcare reforms that improve quality and control cost in order to sustain the total access for all of our citizens to the healthcare system is going to have to result from local stakeholders implementing cost and quality controls at a state level. We're going to need to have committed stakeholders at a local level that are willing to advocate for the whole solution, and they're going to need to be willing to subordinate their own provincial individual self-interest in order to be able to bring about the cost controls that are going to sustain the expansion in the system. So when I think about states' willingness, ability, and readiness in order to do that, I think the willingness goes beyond willingness. It goes to a strong will on the part of individual states to develop their own healthcare policy, because once again, healthcare is delivered at a local level, and cost controls and reforms are going to have to be implemented at a local level. So it's really the will of individual states to develop their own health policy agendas and then use the framework of the federal reforms, use the exchanges, use the subsidies as a nexus for furthering their own reform strategies and agendas. Now, to be sure, even those states that are willing to demonstrate the will to do that, they are going to have some abilities. And I'd put them into a simple 3-point checklist. First, those states that have state governments that are already organizing effectively to implement the exchanges and are resourced in order to be able to do that. Not just necessarily identifying one agency in state government that is now tasked with really what is a large and monumental task in a short period of time of bringing up an exchange, defining what the governance around that exchange will be, and the stakeholders that are going to sustain it over time. So first of all, state government has to be organized in a way to help make reform successful. The second, and I think the most important, are there ample providers within your state in order to be able to accommodate the increase in access to care that will occur if healthcare reforms at a local level are implemented and are sustained, and if the exchange is successful. And then beyond that, are these providers willing to come together and go beyond the fragmented delivery system that exists today in most all of our states and across the country, and organize effectively into integrated systems that provide coordinated care that can ultimately lead to the delivery system cost controls that we're going to need in order to sustain total access of all of our citizens to health care. And then the third ingredient on ability is ask yourself, within your own state, do you have an independent, nonprofit, single state focused health plan willing to serve as a partner to government and a catalyst to healthcare reforms? Sort of like Blue Cross Blue Shield of Vermont. I say that because healthcare is delivered locally, because healthcare reforms will need to be implemented locally, those not-for-profit, independent, single state focused health plans that are not spreading their marketplaces across 12 or 13 different states, or even 3 or 4 different states, if they are able to isolate their focus to only one single state. And then, are those organizations, those health plans, willing to craft their entire program and strategic agenda around supporting the governments and the providers in a partnership mode within those individual states? It can be a huge asset to the individual states in terms of driving a healthcare reform agenda and implementing reforms. 3 years ago, when I became CEO of Blue Cross Blue Shield of Vermont, myself and board members, and I'm pleased I'm here with an alum, Charlie Kirker, who is a board member of Blue Cross Blue Shield of Vermont, and we took the time in November of 2008 to step back from the value proposition we were bringing to Vermont, acknowledging that government was going to have an increased and permanent role in healthcare, and that from our perspective, to realize our future vision, to cover every Vermonter, and to have timely, effective, affordable health care in Vermont, that was a good thing. We were going to go down a crossroads, different from the rest of the insurance industry, and the future identity of our company would be as a partner to government and a catalyst to those healthcare reforms. So the simple checklist is, do you have a government that's organized in the way you need for them to be? Do you have providers willing to alter the way that they provide care? Do you have health plans that are willing to change their roles and align with both? Even if you have the will to develop your own health policy agenda, even if you have government organized, providers ready to change the way they practice medicine, and if you have a single state focused nonprofit health plan willing to support both, readiness, I think, is really the key and the issue of willing and ability. Readiness really does require that even if you have all three of those things, that you have a process in your state by which you're able to bring them all together, and they're able to develop a plan for the future for the state, working with government, and it's going to be a 7 to 10 year plan that is going to have a lot of curves in the road. But healthcare reform does not have a beginning and an end. It's going to be a long-term proposition in which we will have at times 2 steps forward and 1 step back. But I do not see any states, including the state of Vermont, that really has put a process in place by which they will develop a plan for both the near and the long term for healthcare reform. Thank you.
Thank you, Don. We'll move further south to Connecticut.
I want to live in Vermont. We don't have any nonprofit carriers left.
Not in the dead of winter.
True enough. True enough. Thank you. It's great to be with this particular panel and with all of you this evening. Connecticut likes to fancy itself the insurance capital of the world. And with that comes some challenges, and in fact, the strict definition of that is, in fact, we're not any longer. But we have And it's not you either, so don't laugh so hard. No. But we do have a large number of carriers and a large number of insurance jobs in the state of Connecticut. And the lobbying effort at the state capitol in Hartford is rather interesting on any given day. So I'm sure the most interesting part of this discussion is going to be the Q&A. So I'll just give you a little background to help and let you know where we are as a state. I think we would fall, to use Don's frame for a minute, we would fall into that third category as well, in that we've been sort of pushing through reforms, large and small, over the years, largely unnoticed, which is probably a good thing, and trying to sort of focus around the edges and make things a little bit better from a cost and quality perspective in our state. So, Connecticut was one of the first states to put a high-risk pool in place, for example. One of the first states to bring mental health parity online. We created an independent advocate's office, and I was the independent advocate before I became the comptroller, to stand with patients and their families when they get into a tangle with their commercial carrier and try to figure out how to solve that. We're one of the first states, along with California, to ID the post-claims underwriting issue, where some of our carriers were, I think it's fair to say, abusing their ability to go back and look at history after you get sick and take a policy away, leading to some of that work being embedded into the federal reform. And I think we passed the first law in the country to put some speed bumps in the way of that process. So we've been sort of working in the minutia of the insurance law for a long time, sometimes with success, sometimes not, depending on the year. As a state, we suffer because we are really good about the theoretical and knowing what we need to be doing, but when you turn back around and look at what we're doing within our existing purchasing, for example, as a state, we are rather disorganized and not doing things very well, and not aggregating our data, not looking at what we're doing, and not even doing joint procurement of some of the services that we're buying. And so we're buying $7 billion worth of healthcare in 6 different ways that don't talk to each other. And certainly the taxpayers of the state don't benefit from that. And the patients that are covered under those plans don't benefit because of that lack of communication either. As the comptroller, I buy about $1.5 billion in healthcare for state employees and retirees. And in those marginal reforms, we sort of chipped away and grabbed like prescription as an area where we thought we could use, in a rather non-controversial way, our purchasing power to open up opportunities for municipalities, for example, because of the symbiotic relationship we have with municipalities. And then also to allow or to encourage our other state agencies to come in under the same contract. I tell you about that not because it's tied to federal reform, but because as a micro simulation of what we're experiencing as a state around coordinated purchasing and the building of exchange and getting agencies to work together, it's going down the tubes really fast. Because we've got a combination of interests vying for what I call savings, what they call profit or something else, and we also have agencies that like the way things are and really don't want to give up their independent purchasing and autonomy of administration. So lots of challenges. So we're faced with lots of very immediate decisions in our state, some of them organic to us related to the issues that I've already touched on, and obviously a whole boatload of other issues related to federal reform. There are those in Connecticut, despite all the work that we've done around a plan called Sustanet, which I'll talk about in just a minute, who think and say that they think the exchanges by themselves are going to fix all of our problems. And that all we need to do is, put a good bill forward to build the exchange, and it'll all take care of itself. And I reject that because I think there is opportunity for us to use our Uber aggregator sort of position in the market, and also to embed in a pretty immediate way some of the reforms necessary to control costs and do those things that we know, and improve outcomes, obviously, that we know need to happen. The other issue we have is that we've got 2 competing exchange bills. Re-elected Connecticut was one of only one of a few states that elected a Democratic governor in this last election, and we went blue like up and down our constitutional officers. But they say family fights are sometimes more difficult than fights with strangers. So our Democratic legislature is now fighting with our Democratic governor about how far we should go, and should the employees of the exchange be part of the collective bargaining agreement for state employees, like that kind of stuff. So we're not, popping up into the larger issues, at least not fast enough. So the reform effort, and it's called Sustanet now, and that comes out of our state motto, was really based on taking the state's purchasing of healthcare, again, about $7 billion worth, trying to bring that all together, trying to embed those reforms, embed medical homes, embed health IT, because it's a million lives without trying really hard. So if I can sort of pick a health IT scheme for 1 million lives in Connecticut, or the other 2 million that are insured commercially or through our Medicaid program, they're going to follow because we're just sort of big, and we're going to get to drive some of this. And so bring all these populations together, embed those cost-saving measures, open up an opportunity for municipalities to come in beyond pharmacy, but to come into the whole plan, to develop a plan based on the average benefit design in the Northeast for commercial carriers, and then ultimately to reserve that product and sell it on the exchange and outside of the exchange, and in fact create a public option, not without controversy. So the scheme was to create a quasi-governmental and then take that $7 billion and hand it over to the quasi-board and everything will be fine, right? Well, now we've got a new governor who says, well, why would I want to turn $7 billion worth of my budget over to someone else that I may not have any authority over ultimately? And how can we really ensure that this is going to make a difference? Are we building a public option because we can? Or have we been able to model and demonstrate that its presence in the exchange will have an appropriate and impact on pricing in the exchange in general and all of that to make it worth doing? And then what do we do about a tail? And what do we do about the years when it's not sustainable and we have adverse selection in the beginning? So all of that is sort of coming to a collision point in our state pretty quickly. Though there's a lot of shuttle diplomacy between caucuses and the governor's office trying to move it forward, the concern is that the exchange-only people are saying exchange-only, and then on the other end you have the sort of full reform public option people, and then they will not give. And so we're trying to figure out, are there pieces of this proposal that make sense, whether it's a product in the exchange or not, and that will help to inform the larger development of the exchange and the thinking of that new board. So stay tuned, I guess, is the long and short of it. The other piece that we're having surprising problems with, and I'll stop after this, is that last year we got a special sort of dispensation, or it's not the right word, but a special okay from our Attorney General.
Lent, though.
It is Lent, yeah, at least for, yeah. And we're one of only 7 states with a deity in our motto. But we got a special okay from the Attorney General to allow the carriers and the providers in Connecticut to come together for purposes of applying to the feds for a medical home grant. And that was sort of a one-time thing because carriers and providers get nervous about antitrust, and unless you can provide that place for them to do that, they're not coming. Or at least we're only going to talk about one side of the issue and not the money side, which has got to all sort of come together. So that grant didn't get funded, and mostly because we were starting from scratch, and they funded groups that were already ahead of us. But we're out there looking for more resources, or at least to continue the conversation, even if it's only related to the state employee retiree plan that I procure. And we're getting tons of pushback from all over the place. Again, from a new governor who is concerned about loss of authority because it sounds like he's giving something away to me that rightfully belongs to him. And in the weeds, sort of sniper interests that see this as, if we allow them to come together and really talk about these things, the cat's going to be out of the bag. And we're all going to know sort of some of the dirty little secrets that we don't know now. And I don't just mean on the care, I mean across the whole delivery system, including our hospitals. So it looks like it turned a corner recently. We are moving forward and have narrowed it to the point where I'm not even sure it's useful, but it will allow me to bring these folks together, provide some safety from antitrust, and allow them to work for the limited purpose of state employees and retirees for a 4-year period to move this forward. And this is the development of medical homes and trying to develop an ACO structure that will allow us to compensate providers appropriately for things that make sense. So
Thank you.
I'm going to stop. Thank you.
And we're going to move further south, and it's a real pleasure to have our own from New Jersey, Commissioner Considine. He runs a cabinet-level agency. He's in Governor Christie's cabinet, and he's really on the front lines here in New Jersey. New Jersey was one of opened a high-risk pool under the Affordable Care Act and is now doing planning for meeting some of the other requirements of the Affordable Care Act. So we're very interested in hearing your perspective, Commissioner.
Well, it's great to be here. I apologize for being a few minutes late. One would think that state troopers know their way around New Jersey, but that's a different story we could chat about later. But the poor guy's head was the color of a traditional fire engine as we pulled up here. I suppose I am, by nature, the least enthusiastic about the Affordable Care Act. And it's interesting, President Obama has seemed to have co-opted the words healthcare reform, and forever they seem to will apply to this Affordable Care Act when they're not. We have 50 laboratories of democracy around the country that are the 50 states, and healthcare reform can mean different things in different places. And here in New Jersey, we have a governor and an administration that committed to early care, early involvement in the medical system, fighting fraud, and bending the healthcare curve to the right. And to call the Affordable Care Act, in all candor, from an actuarial perspective, at least in the short term, I'm hard-pressed to think of a bigger misnomer on the part of a federal bill. If you take a law and you say that this law has to cover many, many more people, provide many, many more benefits, and by the way, those people are generally going to be sicker than the group was before. Well, for the past 17 years of my job, I worked with thousands of actuaries. You don't need to be an actuary to know that the costs of insuring that pool is going to be higher after that law takes effect than it was before the law took effect. Because before the law, you didn't have to cover as many sick people. You didn't have to cover as many people. And while that's a laudable public policy goal, to cover more people and to cover sicker people, don't fib about it and say that makes it an Affordable Care Act. It's not. Certainly not in the short term. Perhaps are there cost savers there in the long term? I don't know that any of us know, frankly. Aspirationally, there are. But from a concrete perspective, are there? I don't know that any of us know that. We can only hope. But we are a nation of laws, and this is the law in the nation, and we here in New Jersey are implementing the law. So whether that makes us a 2 or a 3, I don't know. In one sense, we're a 3 because New Jersey is a state that was ahead of the curve in terms of healthcare reform. New Jersey is an 80-20 medical loss ratio state, has been for a long time. The 80% in the New Jersey side was all medical claims. That's all it was. That's all it is, as a matter of fact. We're on the federal side, the 80% is claims and then some other things, quality improvements and some other things can count on the 80% side. In New Jersey, it's a pure 80%. So that's a difference there. So New Jersey was ahead of the healthcare curve. And as I'll talk about briefly in a second, that's hurt New Jersey and has hurt New Jersey residents a little bit, which from where I sit has proven to be unfair. How are we implementing? We have an interagency coordination group that's come together to implement. It's led by the governor's senior health policy advisor, a fellow named Bob Schwanenberg. And on it, there were 3 principal agencies, the Department of Banking and Insurance, and I have a designee on that, the Department of Health and Senior Services, and the Department of Human Services, and in New Jersey, Medicaid sits in the Department of Human Services. So that's critical. Additionally, the statewide health information technology coordinator sits on it as well. So you could consider that a fourth seat in the interagency task force. But we do come together weekly, sometimes as conference calls more often than that. And then there are other folks who come in and out. The State Health Benefits Plan is typically one of the principal agencies involved, and they sit in the Department of Treasury in New Jersey. So it is a cross-agency effort. That group has a lot, as you can imagine, of interaction with the Federal Department of Health and Human Services, who has professed to be very, very flexible with the states. About 20 of my colleagues and I went to the White House over the summer last year, and we met with the President and Secretary Sebelius, who herself is a former insurance commissioner. Before she was the governor of Kansas, she was the elected insurance commissioner of Kansas. And I wanted to say, you should get this stuff, but I guess where you stand often depends on where you sit, and now she sits as the Federal Secretary of Health and Human Services. While they profess there to be very flexible, it's sort of the flexibility that some parents have, where they'll talk and talk and talk about being flexible, but at the end of the day, it's only flexible as long as you do things their way. And an example of that is the high-risk pool. New Jersey put one together in, because the ACA said, to do that, and we did, and there was money for it. And ours is called New Jersey Protect, and the single Horizon Blue Cross Blue Shield, which is a single nonprofit healthcare company in New Jersey, originally was the only insurer in the plan. Now there's a second in the plan. Well, we made the argument to Health and Human Services that, listen, New Jersey's different because we're ahead of the healthcare law in the country. We have guaranteed affordability, we have guaranteed insurability, guaranteed availability, guaranteed renewability. So we don't have as many uninsured people here in New Jersey as other states do. In Pennsylvania, right across the river, if you have a good arm from my office, you could throw a rock to Pennsylvania. They had 2,000 people on a waiting list for their equivalent of a high-risk pool. Really wasn't one, but 2,000 people. So the day they opened up their pool under the federal law, well, they had 2,000 people sign up. We had 3. And if you look all around the country, the enrollment for these high-risk pools is far below what the federal government expected there to be. So we said that in New Jersey, if you have a basic and essential health plan, which granted is far better than nothing, but it's really not a rich benefit plan. And to give you an example, diagnostic testing under a New Jersey basic and essential plan that has no riders, diagnostic testing is limited to $400 a year. So if I trip on one of these stairs and break my arm, that's going to be my diagnostic testing for the year, a single x-ray. Additionally, if, God forbid, someone is stricken with cancer, and I happen to be a cancer survivor, chemotherapy is not covered under a basic and essential plan. So we made the argument to Health and Human Services that if someone has a basic and essential plan with no rider, that should not be considered creditable coverage, and those people should be eligible for the high-risk pool and J Protect. And HHS said, no, 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 no. There'll be a run on the bank. You'll be swamped with enrollees. They can't be covered. So now here we are all these months later, and we still haven't hit the 400 number in total enrollees in the high-risk pool. So we said, can't now, maybe we rethink it, and other states have clamored the same thing. Let's rethink the rules. And HHS said, no, no, let's have a deeper discount. That's the trick. Let's have a deeper discount. So let's pick everyone's pocket in the country to have them subsidize their taxes a little bit more to drive a deeper discount. Let's not rethink the rules behind it, because our rules are right. That's our answer to being flexible. So I found that to be a less than pleasant experience. Other ways in which we're implementing is we were very selective in some of the grants we applied for. There's grants that you can apply for under the Act. New Jersey applied for a rate review grant, a consumer assistance grant, and an exchange planning grant. We got all of those. The rate review grant allows us to study what are the drivers behind rates and rate increases. The consumer assistance grant, that's exactly what it says it would be. And the exchange grant, planning grant is we're having forums all around the state with all interested parties, consumer organizations, provider organizations, insurance organizations, other payer organizations, which would be employers and things like that. Because remember, the Department of Banking and Insurance only regulates about 30 to 33% of the insurance market in the state. You have self-insured programs and you have government programs for the rest, so they need to be brought together. There were other grants we didn't apply for example. An early implementer grant. We thought that was a little gimmicky, frankly. We thought that was a plan on the part of the administration to drive healthcare reform faster into the embeddedness of the country in order to make an argument in front of the Supreme Court to say, well, look, it's already part of the very fiber of the nation, and therefore, Supreme Court, you shouldn't overrule it. As an administration, the governor has made the decision not to get involved in that litigation on either side, so we didn't get involved in that. Just an example of that. I'll end with, though, an optimistic note. You know, President Reagan was, whether you agreed with him or disagreed with him, was a very, very optimistic guy. And he used to tell a story about a little kid who got up and would go into a room, and the room was full of horse manure. And it would be the kid's birthday, and he would say, well, I know there's got to be a pony in there somewhere. Well, from where I sit, the pony in this law is the electronic health records. There's two buckets when we think about healthcare spend. One is the administrative bucket, and the other is the true healthcare bucket. Electronic health records provides extraordinary benefits on both sides of the bucket, including additionally, you have the environmental benefit as well. It takes all the paper out of the system. It really provides administrative benefits on that. That's self-evident. And then on the care bucket, I mean, if someone lives just in South Jersey, right now we have regional health information networks, and we're moving very quickly to have a statewide network. So if someone lives in Atlantic City, let's say, or someone lives in Morris County and goes to Atlantic City, and they just happen to have an MRI of their head for some reason, home in Morris County, and then they're in an accident in Atlantic City, well, why should they need to get another MRI if we can use an electronic health network so the doctor down there or the emergency room down there can pull up that MRI as soon as they get there? That's an example. Think about all the allergic reaction tests that can be pulled out when a doctor goes to prescribe a medicine. So I just think that is just absolutely the best benefit. The one thing, no matter where you stand, whether you're absolutely opposed to the law, love the law, or fall somewhere in between, everyone should be able to agree that the electronic health records are there. There are a couple exchange bills in the New Jersey legislature. We've kind of reached out to the sponsors, not because we're opposed to the bills, just because we think they're a little premature because we have this exchange planning grant. We want to say, let's wait until we get the results back from the exchange planning sessions. New Jersey's lucky enough in this one particular sense that the legislature in the state meets every year. A number of states around the nation doesn't meet every year. They only meet in odd number of years. So next year they won't have legislatures in session, so they need to do exchange bills this year. We don't. So we're saying, let's wait till the results come in, the discussions come in. There's actually an academic study being done on what other laws should be changed, so maybe there'll be an exchange bill and there'll be other bills to match it. Should the 80-20 MLR law in New Jersey be changed to reflect the federal law? Obviously, from the provider's perspective and the insurer's perspective, no one wants to have to do any kind of administrative work twice, so there might be some logic to that. So I'll just stop there, and thank you for your attention.
Thank you, Commissioner. I'm going to open it up to, I'm going to ask the first question, but just to give you all time to think of some questions. And thank you for ending us on a hopefully optimistic note. I don't want to take us down too far, but I'd love to hear from the state officials. To go back to Professor Starr's charge, our state's ready, willing, and able about capacity. One concern we hear from states is that, especially given the economic downturn, states don't have the capacity. Do you have the staffing to do this, the resources? I'd love to hear from your perspective on that.
Yes, I think we absolutely do. There needs to be, obviously, a way moving forward. If an exchange, for instance, were to become more vibrantly subscribed than anticipated, what would be the means for that? I think the plan is, I don't want to prejudge the process, but I think in considering current budget constraints, just practical thinking would be that an exchange would need to be self-funding on a go-forward basis. So the capacity would be, if there was some sort of user fee involved in an exchange, well then capacity would be self-funding, so capacity would fund capacity. Use would fund capacity.
I think we're staring down the barrel of a loss of intellectual capability at the state level. I mean, we've got a $3.5 billion budget deficit, a bunch of tier one retirees who are about to go, experiencing what they're calling the fear RIP, which is a fear retirement incentive program, because the collective bargaining units are in discussion with the governor and it's not going well. So I process retirements and they're up 300% over the same month last year. So we're going to have some internal issues within state government, and we're going to lose some folks who've been working on these issues for about a decade, and I think that won't be a good thing. I would agree with the commissioner that the actual operation of the exchange, the administration of that is likely to be embedded in there and will be funded that way. I'm more concerned with the loss of intellectual capacity.
Dick, is that something you're seeing nationally? Dick, are you seeing capacity issues?
Since I'm not a state, I didn't think I had an answer.
But yeah.
And you didn't answer yet. Okay, this is a heavy lift. It is, I've never, in my experience caring about federalism and public management, seen a tougher issue. It is very hard to be optimistic, and will, as you said, as Don said, that's one thing. Capacity another. They're both big hills to climb.
And Don, from the outside,
In the near term in Vermont, I'm not necessarily seeing the capacity. We're debating our own health policy legislation from our new governor. Within that, we're creating a 5-member healthcare reform board. We have identified an agency within state government that will be tasked with managing the exchange when it comes up. We're resourcing the board, but I've yet to see where we've actually identified within the state budget those resources that will bring the board up and get it operational in 2014. The other thing in Vermont we suffer from, in everything from our school systems to healthcare, is small numbers. And the minimal number that's tossed around for making an exchange self-sustaining over time is 100,000. Well, 100,000 is 15% of our population, and if we don't get waivers to include Medicaid and Medicare in the exchange, it's essentially a third of our commercial. So, one of the things that we're struggling with is how do you get that number of people into the exchange over a relatively short period of time to make it self-sustaining. So I agree with our panel and with Dick. This is an enormously challenging issue, and I think it's challenging still for those smaller states.
Can I just say, would that bode well then for the argument in favor of a regional exchange for some of the smaller New England states?
Oh, not in Vermont. In Vermont, we have to do everything ourselves because we're quicker, we're smaller, we're smarter than everyone else. So we do.
You can't get to 100,000.
Right. It gets back to Vermont. I think we'll get to 100,000. It gets back to Vermont has its own health policy agenda. Vermont's going to drive that health policy agenda through the federal framework, through the exchanges. So if that's your strategy, if that is your commitment, then you also need to be committed, despite your small numbers, to having your own exchange, because the federal law does provide considerable latitude to the states to define what their exchanges will look like, the rules, the governance, the types of products that will be in them. So that's all integrated in Vermont's health reforms. We did talk, not me personally, but the state officials did talk to New England states about forming a regional exchange. Their take on this is that in the near term, that might actually be more difficult than bringing up a state exchange, because now you have to talk about interoperability among multiple states to make it happen. And I have had the opportunity to talk to the state health policy officials who engaged in those discussions and tended to agree with them. I left with my head spinning. So I think there's long-term potential for to have regional exchanges. In the near term, I think states will focus on just their own state exchanges.
I'm concerned that the Affordable Care Act is really equivalent to a decrease in the provision and quality of care that patients are getting. We hear about in Arizona where patients have been refused various transplants. In New Jersey, I'm concerned about the difference between mental health care and general health care. We know that in New Jersey, they're closing state hospitals. There's increased overcrowding, much more than there used to be. There are increased incidents of people getting hurt. And I'm just concerned that all of this, these are just examples of what's to come.
Yes.
We're back to me. Kevin, you want to try that, or Commissioner? Yeah.
You're the one closing the hospital. You want to go first?
It's not his department.
It's not my department, it doesn't regulate hospitals, but it's, anything you've seen in New Jersey clearly hasn't been impacted by the act yet, because we haven't begun implementing the act yet, except with regard to the NJ Protect high-risk pool. So how it will bode for the future is
I think
just
that's
speculation.
right. Those are functions of weaknesses in our healthcare market now, and I guess the question then is, when you layer on the Affordable Care Act, what does that mean? I mean, that's, what does that mean going forward?
Right. Well, and it goes to that sort of infrastructure concern and mental health, to use your example, mental health parity and making sure that there is parity between physical and mental health is not so much a payer issue for us or a compensation issue necessarily. It is really an infrastructure issue because we lack beds and we lack providers, and any good child psychiatrist will tell you, I'm not participating with any of those guys, I hate them all and I don't have to. So there's a problem sort of already there that will only potentially be exacerbated by these more lives coming in. The other thing, though, to your other point, and it's the question we don't want to talk about, and maybe the reason why some of these decisions are really ill-placed in the hands of elected and appointed people. But at some point, if you're going to sort of continue down the road of building a system and figuring out what's covered and what's not covered, we're going to have those hard conversations about how old is too old dad to have your cardiac surgery, and how small is the preemie before we intervene. And I think those are important questions because we also, as Americans and as people who have built this union, want to win and succeed and be better and fix it all because we can. But we're going to have those conversations if we continue down. And I don't think that's a bad conversation, but it's going to have to be had. We can't sort of mess around on the edges of this and make believe it's not happening, because at the end of the day, the plan's going to pay for this, and there are going to be things that fall outside the plan, and maybe they are inappropriate interventions, but who's going to decide?
It's only bad when it happens to a relative. Of
Exactly
course.
right. Exactly right. If it were my preemie, would I want it not to matter? Of course not. I'd want, right? But
Can I ask the commissioner from New Jersey a question? You touched on the EMR, the value of EMR. So my question is, can you elaborate a little bit more about how you see this EMR thing can really help reduce the cost, right? So you touched like one example. You said like maybe one person in one city moved to another because the MRI, then you can just pull out the record. So it seems to me you probably imply that through this EMR system, maybe we can reduce some of the redundant cost of the repeat test or something like that. Is that the value, how you see the EMR?
That's partly the value. An additional part of the value is right now the healthcare costs that come about as a result of, I can't think of the right word, so I'll just say the unintended negative effects of people who undergo care that they shouldn't have, quite frankly. And the best example of that would be an allergic reaction or side effects from one medication that impacts either because of another medication they've been on or because of another condition that they have that the prescribing physician or the treating physician at the time doesn't have their full history in front of them because it's in a bunch of different providers' offices in a bunch of different places around the country. If it was an electronic health record that was all there right in front of them, that could be avoided. So there's those costs as well. And then there's simply the paper to non-paper costs.
Yeah, but I guess probably one challenging is that the disease condition may change as a person, right? Move from one place to another. So if you compare EMR, and then this physician may mistreat the patient. And if that happens, then who's responsible? Is it EMR or the physician?
Well, I'm not suggesting that somebody rely totally on the historic condition, but if, if my medical record shows that I have adult asthma, then it will show that I have adult asthma. So it's something, more information allows the physician later in life to make a more informed decision.
Thank you.
Thank you all for coming here today. I'm a second-year master's student here at Woodrow, and I'm actually, full disclosure, headed to HHS after I graduate, so I'm especially interested in...
I have a lot of good friends at HHS. It seems to be a retirement home for insurance commissioners. Joel and Steve and Kathleen.
So I guess my question is, you've all been talking about cost containment in various forms, and obviously we've seen sort of two poles of the debate play out with the Ryan Plan and President Obama's speech today. I'd be interested in hearing from all of you what your view is about the sort of most important levers in the system for containing costs, and kind of as a corollary to that, what your thoughts are on containing costs for the most expensive beneficiaries in the system, individuals with chronic illnesses, and I don't know if there are any promising sort of pilot programs in your states, but are there costs you can be saved for those populations?
Well, I think folks are turning and acknowledging me to answer your question because Vermont does have really one of the major initiatives within Vermont's healthcare reform policy. The Blueprint for Health does focus on people with chronic conditions. It's been in place for about 7 years now. But I think largely, just to answer your question at a high level to begin with, I mean, healthcare cost containment is about changing the way that we deliver care in this country, changing the way that we pay for the care in this country. I think that our care delivery system across the country is enormously fragmented today. We don't have providers operating in systems in which primary care physicians are talking to specialists, and the specialists are talking to hospitalists and discharging, and we do not have an integrated and coordinated system of providing health care today. That's what the federal legislation support for accountable care organizations is to encourage providers to integrate in a way and to integrate their care delivery. So it begins, we have, I think, too much focus on changing the way that we pay providers. Certainly payment reform is a component to controlling healthcare costs, but simply paying providers in a different way. If they don't change the way that care is delivered, if we keep doing what we're doing, we're going to keep getting what we're getting. So, the lessons I've learned from 25 years in Vermont of working providers on health cost containment initiatives is that payment reform with a well-aligned plan for clinical delivery system reform, for changing the way and integrating the way we provide care, over the long term, will control costs, will give us a different outcome in both quality and cost. But they need to be aligned, and it's a long-term initiative. I mentioned the blueprint in Vermont. When I first came to Blue Cross of Vermont in 1993, the prevalence of diabetes in the state of Vermont was 3%. It's greater than 6 today. That's being driven by a lot of things. Poor health habits, the onset of weight issues. But I think that the blueprint for health is focused on creating medical homes in all of our communities, and then community care teams of non-physician health professionals that would coordinate the care for people with chronic conditions, for people with diabetes and cardiovascular disease and asthmatics. And for people with diabetes, it means that there would be health planning sessions going on. So many times today, for all of us who get cards from our dentist or even our automotive, our auto mechanics, letting us know that we have to come in every 6 months. Most physicians do not have registries to identify those people with chronic conditions. So they don't know when they should have them in for their foot exam or their eye exam. When a diabetic shows up on their doorstep for a 15-minute office visit, the physician may not even be in a position to know that they're there that day. So what the Blueprint for Health does at a community level, creates community care teams that will have a registry, will know about all those diabetics, and will be working in the community with those people to help them live well with their conditions, to plan their care. And so when that person is going to see the physician is well apprised of what their state is, what has to happen that day, what exam has to, whether there needs to be a foot exam or an eye exam that day. And so once again, this is part of a long-term plan to make sure that we control people with chronic conditions. Your question about chronic conditions and controlling cost is a very good one and a very good focus, because essentially 70% of our cost of care within the state of Vermont is for people who have one or multiple chronic conditions.
I mean,
Can I just,
hold that thought, and we're gonna. Yep.
the coordination of care, the medical home, I mean, obviously, I don't have to sell you on that. I mean, it's pretty obvious. But as I come from a state where we've got the onesies, twosies, we've got lots of sole practitioners or groups of two, and how are they going to sort of, live in this new world where they need to coordinate care? It's a real challenge. So as part of our medical home initiative, both for state employees and retirees, and as well for the Medicaid population, where we're moving toward primary care medical homes instead of a risk-based arrangement with our carriers, we've had to sort of set up these alliances between these ones and twos and others with the specialists, with others, and make sure that they're on a common network for at least transmitting their medical records between the people in the group, because they weren't. The other is we have a safe harbor provision in our planning bill, in our sustenance bill. That was one of the first things to get yanked, and as a Democrat, sort of moving sort of safe harbor legislation is a bit tricky, but it got dinged, and it created a real problem for docs that we were going to ask to come into this new network and use these clinical standards that had been agreed upon by this group, but then it went away, and it still have to comply. So it sort of wobbles the whole thing. And then finally, back to the sort of collective bargaining negotiations that we're going through now. A lot of the talk is, well, we need to get higher copays from state employees for their pick a drug, right? When I'm saying, well, no, what I want to do is if there's a over the counter equivalent, I want the pharmacist to go out and hand it to them and say, here, go free, run now. And if there's a generic, I want them to get that for free. And it's only sort of those, third tier, fourth tier drugs that I want to really be dinging folks with copays. But the management drugs, I want to not only give it to them without a copay, but I want it delivered to their door, with a postcard.
I would be part of the amen chorus on this. I think, the patient-centered medical home is critical of moving the primary care physician to be, the hub, and have the spokes come out for it are critical. The chronic condition are huge cost drivers. I think, frankly, in New Jersey, as well as other states, the costs driven by out-of-network services are huge cost drivers. Physicians who are able to charge just exponentially higher for the same service. Think in New Jersey, if you go for a 3-shot epidural in network, that might be $2,500. You'll pay your 10%, which is $250 out of pocket. If you were to get that out of network, those same 3 needles would be $25,000 in some North Jersey out of network surgery centers. By the time you run that through usual reasonable and customary, it comes out to about $16,000. Your contract would require you to pay 50% of that. Yet the centers will waive that in a systematic way. Under Medicare, that would be insurance fraud. Under New Jersey law, it's not. That's just an incredible cost driver.
And I want to make sure we let some of the students will go to you, and then Christina will get to you next. Sir?
You could take the students.
Okay,
They pay.
Christina, yeah. Christina, please.
So thank you so much for coming. I actually have a sort of a budgetary question, which I'm now realizing none of you sort of oversee this, but we'll see how.
Kevin probably knows the answer. He's very smart.
I've hit the bottom of everything I know.
So with ACA, it calls for an expansion of Medicaid, but as part of that, until the expansion kicks in, states aren't allowed to sort of cut anyone or to change eligibility. But obviously, all the states are now having budgetary issues. So I guess my question is, what sort of methods do you know about in your state are you using to sort of, deal with the growing cost of Medicaid as you wait for the expansion, even though you can't really do anything about cutting eligibility or taking the numbers off the list?
In New Jersey, the plan is to move as many people as possible in Medicaid into a managed care delivery system for Medicaid, and for the reasons I just discussed on the out-of-network for commercial insurance, it's kind of the same thinking behind it.
Dick, do you want to comment on what you're seeing across the country?
I started saying that this is the Scott Brown effect of the debate that we're talking about, giving the states this huge challenging role that everybody's made sound appropriately and increasingly more difficult. It is a big item for the country. And when you think about it, how much, using the expression, skin in the game do states have? States are going to be covered, going to your point up above, for the Medicaid expansion. The tax credit is paid by the federal treasury to your insurer. The number three group, driving reform, the politics of healthcare are just the toughest that they can be. I've spent a lot of my time, Paul mentioned it, on welfare politics. There's no constituency. If you want to do something and you're in government, you can find a way to do it. You'd like to be able to. If you touch a healthcare reform change, the lobbyists, the campaign contributions, the stakes of the industry specialists, hospitals, pharmaceuticals, you look at the claims they make. Okay, there are all these cost-saving things in the law, and they all sound good, and you've mentioned many of them, the panelists have, and whether they can be set up and whether they can have the big effect that CBO was even willing to buy into, pretty much, or anyway, to a fair extent. It's just overarching question.
Sir.
Having all of you here gives me an opportunity to ask a question that deals with the other side of the economic spectrum. You deal with, we have to have a reasonable debate about what should and shouldn't be covered. What about a debate about a tiering of the medical care system? We're seeing the beginning of concierge practices. Give me $1,600 and I'll give you the kind of medical care you've always dreamed about. Even if much of the funding is from the private purse, that still raises the national health care expenditure. And I'd love to hear your opinions about what's going to happen if we have a tiered system.
But I mean, I don't know as I can offer a whole lot of perspective to your thoughts on a tiered system. But what I would suggest is perhaps we don't need to have the hard conversation about rationing care. Perhaps we don't need to talk about at what age do you not have the heart treatment? At what weight is your baby not premature and to receive that intensive care? And the reason I say that perhaps we don't need to have those hard questions gets back to do we have the foresight and the will to say that this is a 7 to 10 year agenda of completely transforming our healthcare system, to making sure that government, payers, and yes, health plans are changing their roles, entirely integrated, and we're going to change care delivery so that we're delivering the cost and quality that begins to resemble other industrialized countries. And I think if we do that, if we have that kind of will and we go down that road, then I think really the question could be that I think what's in it for us is perhaps we don't need to have that conversation about rationing care. If we don't have that will, and if we don't have that foresight and that commitment to transformational healthcare system reform, and we're not going to do that, then let's go ahead and have the conversation today about rationing care and tiered systems and get to it sooner rather than later. So I can tell you that the commitment of my organization, our vision begins with, and it's a little different than we might see for most health insurance companies, it begins with a transformed healthcare system in Vermont, which everyone is covered. And I would argue I don't want to have the conversation in Vermont about rationing care. I want to transform the healthcare delivery system so at reasonable cost we're able to provide reasonable care for everybody. Perhaps other panels have more perspective on the tiering, but that would be my thought.
Bernard?
My question is regarding Mlr, and thoughts are with regards to MLR, whether or not it actually leads to improved healthcare outcomes or improved quality based on your experience. Well, I know New Jersey has 80 on ILR, and I guess Mr. Georgia, you represent managed healthcare plan. How do you feel about MLR, and do you feel that it compels insurance companies to provide quality care?
The MLR requirements, the requirements of the federal reform is that all individual products have to have at least 80% of the benefit going directly to beneficiaries. For small group products, at least 85% of that benefit going directly to those beneficiaries. The medical loss ratio requirements do not do anything to improve care delivery quality or to control cost. What they do is they hold health insurance companies' feet to the fire to make sure that their administrative costs are kept low. And so it does put a dampening effect there, but the administrative costs are only 10% of the equation. Well, Blue Cross of Vermont, they're 8% of the equation. But so they don't necessarily control clinical quality, but they do make sure that those health insurance companies keep their administrative costs low and they get at least 80% or 85% of the benefits of their premium dollar back to their beneficiaries in the form of benefits. So it is a regulating effect on that industry that I would suggest is not necessarily a bad thing.
It isn't just government that's in the game. There have been there's indications that insurers are concerned about the cost of coverage, and there are among the major carriers in the country important conversations going on about offering a product that involves you're buying into a kind of networking system, a bundling system. You get a better deal from the insurance company. So there are reasons why market forces could help us in this transformational undertaking that you can see also for providers. Providers, AMA, one of their big arguments in this cacophony of debate and commentary is that there's not enough competition. That in 98% of, I'm going to say around 48% of the metropolitan areas in the country, there's one carrier with more than 50% of the market. And that's why there's a lot of interest in whether the Utah version. There are two versions of exchanges out there that people are talking about. Utah says we're going to use a market approach. We're going to be a yellow pages exchange. Every carrier who wants to can come in and compete. And in Massachusetts and in California, they say, no, we're going to be a value purchaser. We're going to decide who's offering a good deal, and we're not going to let you into the marketplace, the exchange, unless we like what you're offering and we think it's priced right and reforms and behaves. Be short about that. So there's a lot of healthcare economics that could work in favor of transformational change. I wouldn't bet on it.
But back to MLR in New Jersey, where there's a track record of MLR because it's been the law for years and years. It's a rigid 80-20. It doesn't have some of the flexibility the federal law does, as I mentioned. Yet, nonetheless, it's 80 on the medical care side and 20 on the administrative expense side. That's the law. But if you look at the actual MLR last year, it ran at almost 87%. So the law is 80%, but the health plans were running at 87%, which means that their administrative costs are only at 13%. So it's really just a floor, but it's a floor that we haven't seen companies hit.
And I would just add at the end of that, the definitions mean a lot in medical loss ratios. It had been symbolic for many years to sort of push the MLR issue and try to get them adopted. But unless they are both policed or regulated in an appropriate way, and you got your definitions squared away, they're really just symbolic and don't mean a whole heck of a lot, I think.
This is our last question.
Okay. On the competition issue, I've heard that actually it's not so much the insurance that's driving the cost, but, for example, very expensive hospitals and that sort of thing. I think in Connecticut, the Yale Medical Center is supposed to be very, very expensive. Are you doing anything from the state perspective to control the very high-cost hospitals and that sort of thing?
Well, we've got a couple of things going on, and one is that we've got a Medicaid program that has historically undercompensated providers and hospitals, and then they've been sort of taking that difference and loading it onto the commercial side, and it has sort of driven up this whole thing. And then we've got teaching hospitals that have special needs, and so there's a lot of consideration. I will only say, yes, we're looking at it. I don't point to Yale in particular. They just happen to be big and growing, and in my home community. And if I get sick, I don't want them to be mad at me. Sort of having all the utilization data, not only for the population that I buy for now, and seeing who's admitting and where, and what are the readmits like, and what are the secondary infections like, and then how do they compare to what these same hospitals are reporting to our OCA, or Office of Healthcare Access, that does. Right. How does that reflect with the general population, and what's the difference? The next step in that really is then, how do I start to drive our folks, with the frozen carrot example from Aetna, into places that sort of the outcomes are better, but without sort of price transparency and quality transparency, which is really hard with these guys. It's in our state. It's almost it's a tough conversation to really hang on to something as being a meaningful decision or bit of learning.
In New Jersey, again, I don't regulate the hospitals, but we're looking very, very closely at the out-of-network issue, as I mentioned. And just another aspect of that is, you could be the consumer who goes to your in-network doctor. The in-network doctor refers you to an in-network hospital, and nonetheless, you end up with, at that in-network hospital, you end up with a radiologist who's out of network, an anesthesiologist who's out of network, and who's the person who looks at the slides? What's that special? Pathologist who's out of network. And you end up with all these out-of-network charges when you had no idea you would be using any out-of-network providers. As a matter of fact, you had every right to expect you'd be using all in-network, because you went to an in-network doctor who sent you to an in-network hospital. So that's got to be addressed as well.
Under the sort of, maybe there's something we can glom onto in the states that's out there now. Maryland's very interesting. Maryland has an all-payer rate system for hospitals, to go to what you're saying, Tom. And not for doctors, not for physicians, but for hospitals. And so I think it's very exciting that this laboratory of states is going to push us to look at your good questions and these hard challenges. And there are lots of things we can learn from that. So getting out and about in the country, that's what Larry and I have been doing, and it's our life's work. I think there's a lot we need to learn about. Conversations like this are always pretty unsettling, but we don't know enough yet. I do think that the way Paul put it at the beginning, are we ready and able? What do you say? You say ready and able, but we don't know if this can be pulled off.
Well, please.
Just quickly, you asked about health hospital cost in the states. There's more focused on hospital and delivery system cost control in Vermont today than any of the time in the 25 years I've been working in Vermont healthcare. The bill that will pass the Vermont legislature this year will convene a 5-member healthcare reform board. It identifies agencies of state government that are work on new payment reform models and delivery system models. So it'll go to that healthcare reform board. They'll be approved by the board. There'll be expectation that private organizations like Blue Cross Blue Shield of Vermont would implement those payment reforms with the hospitals and integrated systems in the state of Vermont, encouraging them to integrate. At Blue Cross of Vermont, our future plans include how we'll integrate with accountable care organizations in the state of Vermont. So it is state government that is driving the stakeholders, and probably, from my perspective, almost too fast right now. So there's a lot of focus on payment reform and delivery system reform.
I'm glad you're here.
I think we all are. This has been a terrific snapshot of 3 very different states, and the view from the new federalism to wrap that up too, and really fascinating insights. And I know we'll be talking about it next Monday to my students, and but really great. And I want to. You want some closing remarks?
Well, if we're not because I just curious in New Jersey and Connecticut whether or Dick Nathan's seen states where they have both nonprofit hospitals and for-profit hospitals, for instance, and nonprofit insurers and for-profit insurers, whether that introduces a somewhat different set of problems than the smaller number of states that have kept the pretty much all nonprofit setup of hospitals and insurers, or at least hospitals. And then there are a few states, I suppose, that have gone entirely to the for-profit. And is that going to affect how healthcare reform unfolds at the state level?
That's an interesting question because New Jersey does have a mix. And I'll just say that there are for-profit hospital systems and there are really for-profit hospital systems. And I think the for-profit hospital systems I think there are some that do it nationally, that they do it very, very responsibly. They play very, very well in the managed care system and would have no impact. I think there are others that are outliers that are cost drivers. We just had an example of a hospital that was sold very recently in New Jersey, and that the whole dynamic behind the sale was there was a fee schedule placed on ambulatory surgery centers that, because of a nuance of New Jersey law, couldn't apply to hospitals. So docs who own some of these ambulatory surgery centers bought a failing hospital and are going to drive all of their business into this hospital, and they say we're going to run our hospital on a for-profit out-of-network basis, essentially just taking advantage of this loophole. So that makes that hospital a for-profit out-of-network outlier, and that's not a good thing.
Well, I think we should thank this terrific panel and thank everybody.